Welcome to today's webinar. My name is Blake Baucom, and I'm the Director of Sales for Osteogenics. Before we get started, let me address how we will be interacting today. From a technical perspective, we can't hear or see you, but we would love to hear from you and be able to answer any questions that you may have. To that end, there's a question and answer button on the right-hand side of your screen where you can type your questions at any time, and we will try to get them answered during the webinar. I introduce Dr. Silva. Dr. Silva is a DDS and an oral surgeon, and she is the board director of Oral Surgery College of the Portuguese Dental Association. After graduation, she was invited to collaborate in the oral surgery graduate program at Oporto University in Portugal. That was from 2002 to 2007. In February of this year, she was invited back to continue her professorship. She concluded a program in implant dentistry at Santiago de Compostela University, School of Medicine and Dentistry in Santiago de Compostela in Spain, and that was in 2008-2009. Dr. Silva completed an advanced surgical master curriculum mastered by Professor István Urban at the regenerative implant dentistry at the University of Szeged in Budapest, Hungary, and that was in 2017. Dr. Silva has been completing a PhD degree in bone regeneration from 2021 until the present day, and that is happening at the Faculty of Dental Medicine and Laboratory for Bone Metabolism at Oporto University. Recently, Dr. Silva has become an invited professor at the Department of Oral Surgery at the Faculty of Dental Medicine at Oporto University in Portugal. Dr. Silva is the president and founder of ARTA, which is the Association of Ridge and Tissue Augmentation, and she maintains a private practice in Aveiro, Portugal. Thank you very much, Dr. Silva. We really appreciate your time, and I look forward to hearing your great presentation.
Thank you, Blake. It's a very nice pleasure to be here in this house, the Osteogenics house, that I'm really appreciate and consider an excellence house, particularly for this topic about bone regeneration. So today I will discuss about vertical ridge augmentation from simple cases to complex cases. So let's start. In our daily routine implantology practice, it's quite common to place implants in even more demanding cases and compromise anatomic jawbone configurations. So it's quite common to produce defects like fenestrations or dehiscences. And we know from the literature that the cumulative implant survival rate is quite higher when we place implants into sufficiently dimensioned alveolar ridges. So it's really important to our patients, if we want to achieve long-term stability of our cases, to incorporate GBR as part of our patient's treatment. So we can find these kind of deficiencies, dehiscence type of deficiencies, in two types of implant sites. The socket sites, like Shu described, when 1/3 of coronal buccal bone plate is missing, 2/3 or no facial wall at all. Or we can find these deficiencies in healed sites, and we can have two different types of healed sites. We can find a thick buccal wall, more than 1.5 millimeter, or we can find thin buccal walls less than 1.5 millimeter. So we know from the literature and from Monge's study in 2019 that placing implants in healed sites when the buccal bone is less than 1.5 millimeter, we observed after 2 months of healing, 3 millimeters of vertical bone loss. So that's pretty significant, and once again reinforce the need to compensate and to integrate GBR as part of patient's treatment. The same author this year in January talks about the significance of this buccal bone wall thickness. And once again, thin buccal bone widths less than 2 millimeters are more prone to develop static and biological complications like periimplantitis. So it's really important to augment these dehiscence type defects because this is associated with heart and soft tissue stability. That's what we want to achieve. So first of all, for this kind of healed sites and to solve dehiscence types like easy or moderate dehiscences, we use this kind of technique proposed by Wong in 2004, that is the sandwich bone augmentation. The sandwich bone augmentation consists first in layering a first layer of autogenous particulated bone graft just on the top of the surface of the implant that is exposed, then a second layer of anorganic bovine bone mineral to protect this first layer of autogenous particulated bone graft, and finally a collagen membrane, preferably a native one. But it's really important to do not forget only to place the collagen membrane. We really need to stabilize this graft. And Eastman in 2016 describes this kind of stabilization with vertical matrix sutures, or we can also use pins, but because we will not enter, it's advisable to do this kind of sutures. We have to stabilize the graft, because if you don't stabilize the graft, you will get movement of our graft. And if we will get movement, we will not achieve complete regenerations of our defect, and in this case, of easy and moderate dehiscences. Okay, but what about socket sites for these kind of dehiscences? What can we do, and I generally perform? I really like this technique developed by José Carlos Rosa from Brazil, that is called the immediate dental alveolar restoration. It's a very simple technique, and we can really achieve very predictable results. So in this kind of technique, we will go to the tuberosity to collect our new buccal wall. And cases like this of easy dehiscences can really regenerate total buccal walls, like you can see in this CBCT. Let me show you one more case. This case is a last week case, so I will not. Sorry? Okay. So this case is from last week. This case presented a moderate dehiscency, already almost severe dehiscency. So in these cases, we just measure the defect with a probe buccally just on the top of the soft tissue, like you can see here. Then you are going to select the right chisel that we are going to collect the bone from the tuberosity, and this is the new fragment that I'm removing from the tuberosity, and we will be the new buccal wall that we are going to regenerate in our socket site. After we place the new buccal wall from the tuberosity, we go back to the same place, we remove another extra fragment, we just particulate it with a gouge, and we just fill the gap between the implant and the new buccal wall. And we just stabilized everything with the provisional. In this case, I use simultaneous CTG as well, but most of the cases I do not perform CTG simultaneously, like I'm going to show you in the next case. But look to the CBCT just immediate post-op after the surgery. We are here reconstructing and creating conditions to have this dehiscence completely regenerated with this technique. So it's a very useful tool and a very simple surgery to perform, and really predictable. So another case of EDR. This patient is a very young patient, once again, 35 years old. She's not a smoker. She's very healthy. And this patient presented lots of ceramics in her mouth, lots of rehabilitation, and of course, all these gingivitis and not controlling bad hygiene. She was not so motivated. So when she arrived here at my clinic, she has a recurrent fistula she wanted to solve. So this center incisor was totally lost. Look at her at the pantomographies, lots of restorations in her mouth. So what we did was exactly as CBCT, we diagnosed the problem, what kind of decency we were dealing with, and we just perform a guided implant placement in the socket. And after placing the implant guidely, we measured once again the defect with a probe, and we select after that the right chisel to go to the tuberosity to collect once again the new buccal wall that we wanted to place in the new socket to regenerate completely the buccal bone. After that, we went once again to the same place, to the tuberosity. We particulated once again with a gauge, and we just cover everything with a provisional. Of course, the provisional has to be made in a way that respects the subcritical and the critical contour, as Oscar Gonzalez described in his paper. So it's really important to respect every single details, so the technique, as every technique, can work. So we seal everything and we wait. We waited 3 months, and after 3 months with no soft tissue graft, this was the appearance of the healing that we found. Of course, Bakalia was not satisfied with the thickness of the soft tissue, and here we perform a soft tissue punch in order to create the right emergence profile, in order to achieve quantity and quality of our soft tissue, and once again, stability of our treatments and grafts. So this is the aspect after 20 days of healing. And look at the CBCT initial. After 3 months, we were using the provisional, and after 12 months of having the final rehabilitation. Look at the buccal wall is totally regenerated. This is clinical control after 1 year, and after now 6 years, look once again to the stability of this case. So everything is regenerated, everything is stable, all our goals were achieved, and that's once again what we want to our patients. So at this stage, at this point, we know how to deal with easy and moderate decencies in healed and in socket sites. Now we are going to talk about severe bone defects, what we should perform in these cases. And we have lots of cases that belong to this category. So when the body of the implant is totally outside the genetic bony housing of the patient, what should we perform? What is recommended is to stage. And if, of course, it's a vertical component that is missing, that's what we are going to talk about, we really need to use a titanium reinforced membrane, a form stable membrane. So we have lots of cases, once again, in different sites that we are going to talk about, and different approaches and how to solve these cases, once again, in order to achieve complete regeneration and, most important, long-term stability of our treatments. Not surgical success, but surgical treatments long time. So we have lots of techniques for vertical bone augmentation. We have GBR, we have Curie technique, we have blocks, we have osteogenic distraction, we have orthodontic extrusion, and we have interpositional graft. Of course, I'm going to focus on GBR because I think GBR can really provide us solutions for almost 99% of our cases. And I'm going to show you only one case of Curie technique that, in my experience, is the only indication for Curie technique. So authors like Massimo Simeon and Vivian Chapuis already talk us about and demonstrated about long-term results of GBR. Of course, we have to know the right indications because sometimes the nature do their job. Like in this case, I operate this case, this Gorlin cyst, and 10 years after, the nature did their job and we don't need GBR. But we really need to identify the indications of GBR. So when it's indicated to do GBR, we also have to dominate all the techniques, and of course we have to know how to select the right material, in particular the graft material, and of course the right membrane. Well, we have lots of graft materials in the market. We have the autogenous particulated bone graft. I didn't include the blocks here. We have the mixture of autogenous particulated bone graft and anorganic bovine bone mineral. We have the sandwich bone augmentation that we have already talked, that is the layering graft. We have allografts, and we also have the synthetic bone. Of course, the autogenous particulated bone graft is still the gold standard, is the only one who has osteoinductive power. So, and we know from Caballé Serrano that this kind of graft releases at least 43 growth factors to the extracellular medium. And it's really important, this kind of medium, and we know that DGF beta 1 and BMP2 has synergetic activity and is really important. They are really important to initiate and progress the osteogenic process. Of course, they are also osteoconductive. They can also have osteogenic cells, but the only disadvantage of autogenous particulated bone graft is fast substitution rate. So another advantage from the blocks and from the unpredictability of the resorbative pattern of blocks is that the autogenous particulated bone grafts are very easy to adapt. They are very less invasive, and we can manage also the complications in case of complications if you are managed with this kind of graft. Another advantage is very rapid vascularized, not what happened with blocks. So Eastman in 2009 described precisely the safety and predictability of using this kind of autogenous particulated bone graft. And most important, he demonstrated the implant cumulative success rate of 94.7% after 7 years loading. So not survival, success implant. So it's a very good graft to use. The same author and Simeon as well, in order to diminish once again the morbidity of our patients, they started to introduce the mixture. First, 50-50% of autogenous particulated bone graft and anorganic bovine bone mineral. The goal here was to augment the exposure of the osteoinductive growth factors that were released from the autogenous particulated bone, and from the other hand, increase also the osteoconductive surface of the xenograft. So what happened with this mixture biologically? When we are talking about horizontal augmentation, it's about 6 months of healing. And when we are talking about vertical augmentation, it's 9 months of healing. So during this healing, most of the chips of the autogenous bone graft are resorbed and are substituted by new bone. And this new bone is going to incorporate the particles of the xenograft, like you can see in this image of one of my cases. So we have the best of the two worlds. We will have the biological information because we have new bone, and we'll have the dimension stability of our graft because of the xenograft. So for horizontal and vertical augmentation in GBR, the ideal graft is the mixture at least 50-50 of anorganic bovine bone mineral with autogenous particulated bone graft. Of course, in my practice, I try to have the most quantity possible of autogenous particulated bone graft, and most of my cases are 60% autogenous, 40% xenograft. Okay. What about the membranes? We also have lots of membranes in the market. So we have the non-form stable membranes like this one. It's a collagen membrane. These kind of membranes are used in horizontal augmentations. So we don't need titanium reinforce We don't need form stable, and with this kind of membranes, we can achieve very predictably horizontal gains, very significant horizontal gains, and very predictably with the sausage technique. And then we'll have the form stable membranes. The form stable membranes are indicated when we want vertical augmentation. It's really mandatory to have a form stable membranes. And once again, we have lots of membranes in the market. We have the metal ones, the titanium mesh, that are very good membranes, but they are very, very difficult to remove. And sometimes in these cases, we are dealing with baby bone, very sensitive and immature bone. And when we are removing this kind of membrane, the immature bone comes along with the membrane. Then we have the synthetic membranes, and polytetrafluoroethylene is one of the most indicated ones. We have lots of membranes in this field. We have the expanded PTFE, that is the old Gore-Tex. We have the dense PTFE. We have the modified expanded PTFE developed by Dowling in 2017. And more recently, we have a PTFE mesh developed by Eastman Urban in 2021. So, once again, if we want to achieve vertical augmentation, we will need titanium reinforced membranes, and PTFE is one of the membranes that should be selected. We have lots of documentation, scientific documentation on this topic, and authors like Tinti and Benfenati, as well as Sasha and Simeon, describe lots of complication in the past, because most of their cases were done with the Gore-Tex, that was a membrane that is not anymore exist in the market. So in 2009, Eastman demonstrated that it's really possible to use inclusive the expanded PTFE with much less complications, only 2%, 2.78% complications, not those percentage that in the past was presented, because the surgical technique was modified and the exposures were not so common. Then in 2014, Ronda compared both expanded and dense PTFE, and what he concluded was that both could produce very nice results, but when we deal with complications, dense PTFE is much more easy to deal and to save graft in these conditions. Then in the same year, Eastman published a prospective serial cases using dense PTFE, and once again, he didn't report no complications, because once again, the technique was a little bit modified. In 2017, Dowling presented this kind of modified expanded PTFE that is a good membrane, but in case of exposure, rapidly infects. So we have to manage and pay attention to that. Finally, in 2021, Eastman developed this kind of mesh that is much better than the metallic one. It's much easier to remove. And in cases, especially in demanding biological cases, it's recommended because of their rapid vascularization as well. So when we are talking about vertical regeneration, absolutely dense PTFE titanium reinforced membrane is indicated. And posterior vertical mandible defects are a classical indication for this kind of procedures. So the first case I bring to you about posterior mandible defect is this case. A patient, a very young patient, 58 years old. He presented lots of defects because of periimplantitis in all parts of their posterior mouth, both maxillary and mandible. So what we advise after, of course, periodontal control of this patient and motivation, we started the explantation of the posterior mandible implants, and we did the vertical augmentation in the posterior maxilla. And after 2 months of healing, this was the vertical defect that we found. So we entered the case, we designed the flap very safety, including 2 teeth away from the defect, and we started our lingual flap advancement. our modified lingual flap advancement with the myloidal separation and respecting the insertion of these fibers. We collect the bone from the mandibular ramus, we mixed everything, and after fixating the membrane lingually, we pack the graft and we finish the advancement in the lingual part. And after doing as well in the buccal part, everything is closed with a double layer suture in order to avoid any kind of exposure in the future. This will guarantee us that the exposure will not happen, or very rarely. So because we are talking about vertical augmentation, we had to wait 9 months. We have to wait a pregnancy. We have to wait that our baby bone will mature as much as possible. That's what we did. And after 9 months, this was the CBCT of the left side. So in the mandible, a more immature bone. In the maxilla, I had a more mature bone because meanwhile it passed 2 months in front. And I will now re-enter the mandible. And when I re-enter the mandible, I'm removing the PTFE membrane, and look what I found, this very, very mature bone already. So here we achieved 11 millimeters vertical bone height from the initial and from the baseline that we were. Then we place our implants, always respecting and using biological drilling. At this stage, we also perform a micro sausage that is called a protective one in order to prevent, again, a second bone remodeling. And we close everything. And after 3 months, we start to prepare the soft tissue. And only after prepare the soft tissue, 2 months after, we will do the uncovery and we will do the rehabilitation. And once again, what we want to achieve is stability of our treatments. Meanwhile, I re-enter the maxilla. I'm just wanting to show very fast. Look to the difference between the initial and the final in the maxilla in the same patient. And finally, once again, the patient rehabilitated in the maxilla and in the mandible with stability of our case after 5 years long. Perfect. Let's go to the second case of mandible. This patient was a patient that needed once again to be motivated. She presented lots of restorations, lots of biofilm to control. So after she was motivated and periodontally controlled, the CBCT was very demanding. So this kind of CBCTs shows us that it's going to be a very hard host to regenerate. So we perform exactly the same protocol like I described before, and this is the membrane in place and everything is stabilized. And 9 months after the healing, this was what we found in the CBCT. So the CBCT was promising, but we really need to re-enter and see. We achieved at least 6 millimeters high. This is the re-enter. We used exactly the same flap design. And we are removing now the pins, and underneath the membrane, this was the bone that we found, a perfectly vital, and the angiogenesis is very visible here. So we prepare our implant bed. Look to the horizontal gain and to the vertical gain. We have a new crest here. Once again, a very young patient, 40 years old. So we are preparing here the bed of the implant. Look to the vascularized bone that we are seeing here. We had the opportunity to remove samples from this implant bed, and once again look to the histology of this case. So we place our implants. After 3 months, we start our soft tissue management. Then we do our rehabilitation once again to get stability of our treatments over time. Perfect. So what about anterior vertical defects? When I started this technique, my goal was the posterior vertical mandible. That was my really goal. I wanted to solve the posterior mandible. Nowadays, the most demanding are absolutely the anterior vertical defects, especially when the patient arrives to us with 2 surgeries or 3 surgeries already done before. So the periosteum is really calcified, and we have to manage the periosteum, do perioplasties, and do the suborbicularis preparation. So are really most demanding cases, in my opinion, at least. So the first case I bring to you from anterior defect is this patient. Once again, very young, 43 years old. He has a trauma history past because he plays soccer. And this is our diagnostic planning here. So the central incisor is completely lost, resorbed, no buccal wall at all. So we did the wax up of this patient in order to program our treatment plan. So what we did here was we decided to extract the central incisor using this kind of flap design, and we included also the lateral incisor because it was microdontic. So in our wax up, we decided to extract the lateral as well. We measure the defect and we collect our autogenous bone graft once again from the mandibular ramus, and we mixed our autogenous chips with anorganic bovine bone mineral in order to get our mixture and our ideal graft, like I talked to you before. After this, we select the membrane, the right size of the membrane. We fixate in the palatal side. We prepare also the recipient side of our graft, and we pack everything with our mixture. It's really important to advance the flap, and this is the periosteoelastic technique that allows us not to be so invasive and allows us to advance the soft tissue in order to cover everything and do not get any kind of exposure of our graft that we do not want to that happens. So after performing the periosteoelastic technique, we suture with non-tension. It's really important to get non-tension, especially in the anterior zone, because we have lots of muscles there. And we are going to perform our horizontal matrix and interrupted sutures as well. 9 months after, this was the healing. And we didn't have any kind of complication, and we entered the case. When we are entering the case, this was the bone that we achieved once again. So very vascularized, very, very mature already. So look at the implant placement of this case. The bone doesn't move. So everything is really stable, and it's very easy to perform this implant placement at this stage. So we correct once again with the corrective sausage, and we close everything. And after 3 months, we are now at this point in this case, we are now dealing with the soft tissue management. So I will not going to show you the final case, but I'm going to show the final case in this patient. This patient is a Marine, is 37 years old. He has, once again, a history of trauma. And in 2006, he just had a bicycle accident, and he just had to do these reconstructions of both central incisors. After 14 years, the colleague that referred the case to me saw him and identified his fistula, and after that extracted the tooth and sent to me. When I saw this patient for the first time, this was a defect, so a very severe defect in the anterior zone, and also the other central incisor, also very, very committed with a fracture, also in the root. So after healing, 2 months after, we decided to enter. So we performed this safety flap once again, including 2 teeth away from the defect. we are going to regenerate both central incisors area. Here we use a bone dense graft. We mixture trephines milled in the master mill and also bony chips, and everything mixed with an anorganic bovine bone mineral. And we use the same protocol. We fixate first in the palatal side. We pack everything very well in our defect, and then we stabilize in the buccal area once again with pins. Then we just cover everything with a collagen membrane to prevent the edges sometime of the membrane that can be aggressive to the soft tissue, and we advance the flap with the periosteoelastic technique like I showed you before. This patient will wear an Essex during 9 months of healing. And after 9 months of healing, this is the clinical aspect of the patient and the CBCT that we perform after that. So we design here a surgical guide based on this CBCT, and we performed the re-entry and, of course, the implant placement. So I'm re-entering the same way I did before and removing the membrane. This is the bone that we find here. So everything, once again, very vascularized, very stable. We have a new ridge prepared to do our implant placement. And we drill it biologically using very low rotations with no irrigation. We place our implants, we overcorrect with a mini sausage, and then we stabilized everything with a vertical matrix suture. And finally, here I'm using also a collagen matrix to augment the thickness at this stage. We can use the autogenous, but here I'm using a channelogenic one. And 3 months after, we are going to prepare our soft tissue management. And after only that, we will do the uncovery. And finally, the prosthetic of this case and the tissue management, the prosthetic guided tissue management of this case. So now the patient is rehabilitated and very with a very stable scenario from here. So now I'm going to show you the only situation that I do not use GBR. This patient, 33 years old, she arrived with this kind of socket defect, so a moderate dehiscency. So what I proposed to her was an EDR, but she didn't accept it. And 2 months after, she came along with an implant on her hand. So I performed a new CBCT, and the defect was far away more severe. So remember the Monge study, 3 millimeters after 2 months, that's precisely what happened. Now I have a mini triangle on the basis, so a much more difficult defect to solve. So in these cases, when I have very narrow defects and when the bony peaks of the neighboring tooth are not leveled, I prefer to use the Curie technique. So I remove this kind of block from the mandibular ramus, I split it, and I fixate it here, buccally and lingually, and I just fill the gap with autogenous particulated bone graft from the same donor side. Then I stabilize everything, and we wait. What is recommended is 4 months. I prefer to wait a little bit longer. I waited 6 months. And after 6 months, this was the CBCT because it was a really demanding base defect. And this was the re-enter that I found after 6 months. So look to the initial, look what we will get after 6 months. This is the occlusal part. So we prepared now our implant bed. I used here a slim fit healing, and I am performing here a connective tissue as well to augment at this stage the thickness of the soft tissue, and I let it heal. After soft tissue management, this was the case that we could get in terms of papilla and the healing after 2 more months. And finally, the final prosthesis and the papilla on the right side. And this was the case concluded with Curie technique. That, once again, in my opinion, is the only case that I recur to that technique. Otherwise, GBR will solve all my cases, at least until now. Perfect. So we talk about posterior mandible, we talk about anterior defects. We now are going to enter in the posterior maxilla and then in the totally dentulous cases. So in the posterior maxilla, we have a combined defect. So we can have the pneumatization of the sinus combined with the resorption of the ridge, or we can have only pneumatization or only resorption of the ridge. And that's why we have to know what the patient really suffers in order to correct and to regenerate precisely the defect. So Stuckey proposes, when we have less than 3 millimeters of ridge in the posterior maxilla, he proposes us to stage, because otherwise, especially in very wide sinus, it will not be predictable. So in this posterior maxilla and recurring to GBR techniques, we can only perform sinus bone augmentation if our defect is only due to the pneumatization of the sinus. We can have to we can combine sinus augmentation with horizontal bone augmentation using the sausage technique if we have both components, the horizontal and pneumatization of the sinus. We can have to combined with the PTFE membrane if we have a vertical ridge augmentation resorption. And finally, we can only do horizontal augmentation if we don't have pneumatization of the sinus, or if there is a hypoplastic sinus, or only vertical augmentation. So the first case is this case, a very common case in the posterior maxilla. So this patient has pneumatization of the sinus combined with vertical bone loss of the ridge. So we performed here a sinus augmentation with both windows because of the artery, and we combined with the PTFE membrane to correct the vertical ridge defect. This is the membrane in place, and after 9 months, this patient could be rehabilitated with no pink ceramics, so a very improved ratio crown implant, much easier to clean for the patient. But sometimes we have more atrophic cases like this one. This patient has a sinus pneumatization, very, very severe, and also an horizontal component that is missing. So we propose to her to do bilateral sinus augmentation with bilateral sausage technique on both sides. Look to the horizontal deficiency, so very narrow ridge. We are performing here now our window, and we like to perform the sagittal sinus augmentation that allows us to get the best bone in the middle, because we place xenograph in the medial and lateral parts of the sinus, and in the middle autogenous particulated bone graft, and simultaneously our sausage technique with our bone mixture with autogenous and xenograft. So this is the sausage in the right side. We advance. This is on the other side. We did exactly the same technique, and look to the sausage and the volume that we wanted to achieve here. Everything is stable once again. We advance the flap, and now, because it's an horizontal augmentation, we will re-enter 6 months, only 6 months after. So after 6 months, this is the reopening. Look to the bone. It looks like native bone because the collagen membrane, the native one, transvascularized really fast. So look at the bone. It really looks native bone. We place our implants, and we did the same thing in the other side. And now we are performing the corrective sausage, and this is the final case. Once again, our crown implant was improved, very easy to clean to the patient, and no pink ceramic again. Okay, so we have other cases. We have other cases that we need to combine sinus augmentation with vertical ridge augmentation. This is one of the cases. So this patient has a very atrophic maxilla with a vertical component. Sometimes with horizontal augmentation using sausage technique, we can correct 2 millimeters high, but when we have more, we need to use form stable membranes, because otherwise we are not going to achieve that kind of vertical augmentation. So we perform on both sides the sandwich sagittal sinus augmentation, and after that we perform the ridge augmentation, vertical ridge augmentation, using dense PTFE on both sides as well. So this is the other side, and once again we need to wait 9 months, and after 9 months this is the healing and this is the reopening. And when we're reopening this case, this is what we found. Once again, a very vascularized bone, vital one, and we can now perform our implant placement in the correct position because we have a new ridge. After 3 months, this is the mucogingival distortion that we need to correct, and we use the strip technique to do that. We reposition the mucogingival line, we augment the keratinized tissue using this kind of material, and this is the healing, and this is the prosthetic tissue management after more 2 months and the patient rehabilitated. Okay, but in some cases, and I'm going to show you 2 more cases, we don't have sinus, or we have a very hypoplastic sinus. So in these cases, we only need to perform vertical ridge augmentation. So look at this patient. This patient has a very demanding ridge, a very atrophic vertical deficiency, about 10 millimeters in the premolar area. So here we collect, once again, autogenous particulated bone graft from the mandibular ramus with a safe scraper. We mixed everything with anorganic bovine bone mineral. In this patient, I perform a PTFE mesh in the right side, and in the left side, a conventional dense PTFE. So we fixate in the palatal side, like I described the cases before. We pack the graft perfectly, and we cover everything with a collagen native membrane. Here I'm using also fibrin, and this is the healing 10 days after. So everything is okay. Patient doesn't feel pain. She has a little edema and some hematoma, but not significant one. And 9 months after, we re-enter the case and look to the CBCT that we found on both sides. So I'm re-entering now, and I'm re-entering with the same flap. This is the left side with the dense PTFE. Look at the bone that we achieved here, and look at the histologies and the mature bone that we have here, involving all the xenograft particles that we wanted to get. In the other side with the mesh, we observed exactly the same. Of course, we are going to have more infiltration of the soft tissue, but because it was a very demanding case, I need rapid vascularization, I used here the mesh. And look to the initial, look to the bone we will get, and look to the histologies. Of course, here I will have a more mature bone because it vascularizes faster, so the healing process, it will be faster. That's why I will have a more mature bone here in these histologies. So this is the before the vertical ridge augmentation. This is the after, what we will achieve. This is the new ridge. So now it's prepared to do our subcrestal implant placement. And we place our implants, we overcorrect with a sausage, and 3 months after, we are doing our soft tissue management once again. So it's really important to do soft tissue management in order, once again, to reposition all the distortion of our mucogingival line, but also to augment thickness and to keratinize our tissue, because it's the soft tissue that it will protect our grafts for sure. So now this is the healing. Now is the prosthetic in place right now. And of course, the patient is happy with the final result, because finally she could get a fixed prosthetic and solved her problem. Okay, final case. This case arrived me in 2017. I was starting my program at Eastfans. A very young patient, 45 years old, and completely uncontrolled nervous anorexia, and a smoker. So the first thing we did was to refer this patient to control her anoretic problem. And of course, she had to give up smoking, because otherwise we could not help her. She was so motivated that 2 years after she started her anorexia control and stopped smoking, she came to us, and this was the CBCT that now we found. So, of course, it was an even more severe defect that we observed at first, but of course we could not operate this patient. She had to be controlled first medically, and we performed here a vertical ridge augmentation using both matches on both sides. We cover everything, and we use here fixed provisional. That's why I call this technique the provisional all on three, because we used a provisional on 3 implants. So after the healing, 9-month healing, this was the re-enter. And I'm removing the meshes, and this is the bone we found. So once again, even more mature bone, because of course the vessels enter faster because of the PTFE mesh. And this is the gain horizontally and the gain 7 millimeters vertically. And finally, we have a new ridge, and we can now place our implants in the 3D correct position. Now it's time to do the same thing in the other side. We like to overcorrect once again with the protective sausage, and this is the mucogingival distortion that we need to correct and do our soft tissue management. And finally, we enter the prosthetic phase. And of course, this patient on the delivery day, she's starting now a new life, because she finally can smile and have the auto confidence that she was needing. And this is the most grateful thing to us, of course. And here she is with a new smile and a new life with no makeup at all. So we have a new person back to life. That's what we really appreciate. So once again, vertical augmentation using GBR can be predictable, even in extended vertical bone defects. Urban talks us about 1 millimeter bone remodeling. Simeon talks us about 3 millimeters, but the technique is not exactly the same. And what we can conclude is that this technique is sensitive, but is really predictable, and it worked. And of course, the favorable long-term clinical outcomes validate her. So do not forget to select the patient, prepare the patient to this kind of surgeries, because the results really happen and can be really predictable. So once again, I would like to thank Osteogenics for this opportunity. It's a great honor to be here and to talk about this topic that I'm really passionate of. So thank you so much.
Dr. Silva, the pleasure is all ours. Those are beautiful cases, and the results that you're getting for your patients are I mean, it's really amazing. So congratulations on the great work. That's really cool to see. There's a lot of good questions that have come in. We're a little bit short on time, so I'm going to try to get through a couple of them here. Can you elaborate on the mini sausage and when you use the mini sausage and kind of the benefits of that?
The mini sausage is to protect the bone remodeling. When we enter the case to do our implant placement after bone augmentation, of course, when we are opening a flap, the bone will defend, and you will start the bone remodeling process. So in this kind of procedures, we place our implants subcrestally, and we do this kind of mini sausage in order to compensate some resorption that we will get. It's only to be protective. Of course, you can. It's acceptable to do implant placement and to do CTGs to augment the thickness of the soft tissue in order to protect. But we like to do this kind of mini sausage and simultaneous, most of the times, soft tissue management as well to augment thickness and once again protect our grafts, especially the biggest ones, because they are most submitted to this kind of bone remodeling.
Great. Sorry, I'm going to go through them kind of quick. So I would typically ask a follow up there, but I'm trying to get through these. How do you temporize after a vertical GBR in the aesthetic zone? I know you just showed that case, but when you don't have the possibility of doing a fixed temporary bridge, the doctor is saying, I find that Maryland bridges are really not practical. So what's the way to temporize those cases?
Most of my cases, I use an Essex. That's the most of my cases. I prefer to use an Essex. The patient removes, cleans well. So most of my cases, I don't use Marylands. I prefer Essex.
Okay. I know you showed this also a couple of times when you're talking about the biological drilling, but why are you using no irrigation when you're drilling for the implant?
Because the biological drilling is precisely, I use very slow rotation, 50 rotation per minute. And I only use the irrigation in the first drill. It's 800 when I use the first one. The other ones are with no irrigation because are really very low rotation. So in that case, I can respect even more biological the bone during the drilling.
Okay, perfect. Looks like we've got time for one, maybe two more questions here. So can you explain how you decide between using a dense PTFE titanium reinforced membrane or going with the sausage technique for the with a collagen membrane? When do you decide between the two?
Yes. So when I augment it horizontally, I only need a non-form stable membrane. So I use sausage technique. I don't need a form stable membrane. I use a collagen native membrane. That's when we need only horizontal augmentation. When we perform vertical augmentation, we really need a titanium reinforced membrane. So we will need a dense PTFE titanium reinforced membrane to augment vertically. So,
okay. So you make it pretty simple. If it's horizontal, we go collagen. If it's vertical, we're going with the dense PTFE.
Yes.
Pretty simple. This question I'm going to ask you here, I think you can spend an entire lecture on it, so maybe we just go for a real brief explanation. But how do you manage PTFE membrane exposure whenever those happen when the patient comes for follow-up?
It depends if I have a low-grade infection, if I don't have infection, or if I have a high-grade infection. That is a very extended topic. So if the patient arrives with an exposure but no signs of infection, no pus, no swelling, no pain, I will try to maintain the exposure clean, and I use doxycycline paste to clean. Saline first, and then I apply a paste of doxycycline, and I try to preserve the membrane at least 6 weeks. But if the patient arrives with a high grade infection, with pus, with swelling, with fever, I have to remove that membrane right away. Then I have the other scenario. I have an exposure, and I have a low-grade infection. In those cases, if it passed more than 6 weeks, I can remove the membrane, clean everything, and cover everything with the collagen membrane and close. But if didn't achieve yet those 6 weeks, I will try to do the same protocol that I explained before with no infection. So I clean everything with saline, I apply the doxycycline paste, I give antibiotics to the patient at least 1 week, and I'm control him very near in order to achieve those 6 weeks, and then I removed and I substitute with the collagen, and I wait the 9 months that I need to wait. And then when I re-enter to do the implant placement, I do an overcorrection by then. But most of the times with low-grade infection and exposure happens by pressure of the provisionals. And in those cases, it passed already 6 months, so I just can remove the membrane right away. That's not a big deal. I have cases that things happens because the patient goes away from the country and I cannot control them so often, and we just remove the membrane. Then after when we achieve 9 months, we can do our implant placement and we overcorrect by then, and the case is perfect. So that's the advantage of this case. That's the advantage of using this kind of particulated graft. We can save the grafts. It's not like blocks in the past.
That's a great answer. And I know you could have lectured on that for an hour by itself if you really wanted to. So thanks for the concise answer there. I think we've had a lot of really good information. Of course, there's more questions that have come in, and Dr. Silva, we may interact with you to try to get some of those questions answered if that's okay.
Okay.
But I want to thank everybody for your time today, especially you, Dr. Silva. It was a great lecture, really good information. I think a lot of good key points for the clinicians to take back and work with their patients on. So thanks so much for your time. We'll be sending out a brief survey for feedback on this webinar. So we'll really appreciate the answers that can come from that. And we will sign off there. So Dr. Silva, thanks again so much for your time. We really appreciate it.
Thank you so much. I hope I will be helpful to my colleagues. And once again, thank you so much for your support. Bye-bye.
Perfect. Thanks, everybody. Goodbye.